Hi, everyone. Thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus, and I'm here to welcome you to today's presentation, Eliminating Tuberculosis Through Sustainable Financing Approaches. We have a fabulous broadcast for you today, and we'll begin with just a few announcements. So first of all, thank you all for being so flexible with the change in venue for this webinar. Web conferencing platforms are experiencing very high volumes, and GoToMeeting has been performing better for us this week, so we made the choice to move it over here. Please do bear with us if there are any technical hiccups during today's broadcast. We'll do our absolute best to very quickly troubleshoot if anything occurs. But we should be fine. And secondly, this broadcast is being recorded, and we'll make the link and slide deck available shortly after the broadcast. And this is probably the most important announcement. We ask that if you're not speaking, that you please mute yourself to keep the line nice and quiet while others are talking. We'd really appreciate that. Thank you. And lastly, we would love to hear from you at any time, and we welcome your questions. So to do so, please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions. And if you've already collapsed your little console so it's just a little column, it's the orange little kind of cartoon symbol with the 3 dots in it for you to enter a chat. So that is it in terms of announcements. It is my great pleasure to hand it over to my colleague, Denise Zilferberg. Denise, take it away when you're ready.
Thanks, Bethany. Good morning, everyone, or good afternoon or good evening, depending on where you're joining us from. Thanks for tuning in. In this webinar, we will cover sustainable financing approaches for the TB response, drawing from experiences in 3 countries. We have 3 speakers today: Catherine Cantelmo, Thomas Fagan, and Dr. Gafar Alawadi, who will speak about experiences of Cambodia, El Salvador, and Nigeria in sustainable financing for TB, the challenges encountered and the lessons learned in these countries. This will be followed by a short discussion on how the private sector can be leveraged to sustainably fund the TB response, with Irene Duta providing an overview of what we can learn from Indonesia and a few other countries. Tuberculosis is a communicable disease and is one of the top 10 causes of death worldwide. According to the World Health Organization, TB is the leading cause of death from a single infectious agent. In 2018, an estimated 10 million people fell ill with TB. There were around 1.2 million TB deaths among HIV-negative people, and an additional 251,000 deaths among HIV-positive people during the same period. As illustrated in the diagram, the burden of disease is concentrated in Asia, including Central Asia and Africa. While progress has been made in the last few years, with both incidence and mortality rates having gone down, much remains to be done to curtail the epidemic. In a concerted effort to respond to this epidemic, development partners and countries most affected have made commitments to end TB. The 3 global commitments to end TB include the Sustainable Development Goals, the End TB Strategy, and the Moscow Declaration to end TB. These commitments include setting targets and timelines by when to achieve the targets, strategies to reaching those targets as well. One of the pillars of the Moscow Declaration framework is ensuring sufficient and sustainable financing for the TB response. TB disproportionately affects the poor population in most countries. These are the same people who are most vulnerable to catastrophic health spending, meaning they get pushed below the poverty line due to out-of-pocket expenses they incur to obtain health services. This is one of the reasons why TB financing is an important policy issue, alongside other reasons such as TB patients incurring significant indirect costs from seeking services and treatment being longer and more intensive than other infectious diseases. Additionally, the need to sustainably finance the response is important to curb the epidemic, given that there's high donor dependency in high burden countries. I will hand over to Catherine Cantamo, who will be speaking to us about Cambodia's experience, focusing on evidence generation to provide policymakers with a clear picture of the health and economic impacts of TB detection and control.
Great, thank you so much, Denise. So as Denise just said, my presentation this morning is going to focus on how we generated evidence for a TB investment case in Cambodia. And I worked on this analysis with some colleagues listed here. So while Cambodia, next slide. While Cambodia has made significant strides in scaling up TB case detection and treatment, leading to a 73% reduction in TB-related mortality and a 43% reduction in TB-related incidents in the last 17 years, the country still has one of the highest burdens of TB in the world. And the TB program still relies heavily on external funding support from the Global Fund and USAID. Additional public investment is essential to meet program targets and protect households from catastrophic TB costs. So as Denise said, in many countries around the world, TB disproportionately affects the poor. That's true in Cambodia as well. And costs of TB exceed 40% of household income for about 1 in 5 TB patients. Next slide. So to advocate for increased resource allocation to TB from the government budget, the program needs to present evidence on how the investment in scaling up TB prevention, case detection, and treatment will result in improved outcomes. While many countries have experience in developing investment cases that show how public investment in health results in improved health outcomes, very few explore the household economic benefits, and even fewer consider the indirect costs associated with being ill. So we estimated both the health and household economic impacts of greater government investment for scaling up and improving TB services in Cambodia. So throughout this presentation, we will focus on this impact modeling, but the broader study also looked at costs and fiscal space for scaling up TB services in the country. So for health impacts, we estimated how scaling up TB screening programs and rates, improving diagnostic algorithms, including full coverage of more accurate testing, and increasing coverage of child contact investigation and preventive therapy, reduces TB incidence and mortality, and compared this to a baseline scenario where intervention coverage and diagnostic algorithms stay the same. For household economic impacts, we estimated future household spending of both direct and indirect costs of TB under the baseline and scale-up scenarios. Direct costs refer to both medical and non-medical costs, such as transportation, that are associated with TB testing and treatment. And indirect costs refer to lost wages and to saving as a result of TB. Next slide. So this diagram shows the potential pathways for improved health and economic outcomes from scaling up and improving TB services. So scaling up active case finding, in Cambodia, they have a pagoda-based screening program that they're aiming to scale up. That reduces the time it takes to spread TB and therefore reduces new infections. Improving diagnostic accuracy by changing the algorithm so all testing is done using X-ray and GeneXpert also results in fewer false positives and negatives, which helps people get the care they need sooner and also reduces new infections and TB-related deaths. And increasing preventive therapy obviously also reduces new infections. So these reductions in new infections and TB-related deaths result in fewer people needing TB treatment, as well as fewer people in the labor force dying prematurely, which in turn reduces the number of facility visits needed and days missed at work due to TB, which then reduces the direct and indirect costs associated with TB. Next slide. So to estimate health impacts of improving TB case detection and treatment from 2018 to 2025, we applied a mathematical model called time impact, which uses epidemiological trends, diagnostic algorithms, and TB intervention coverage to estimate the disease burden and how many people will receive TB services. The model takes into account different types of TB, including MDR-TB and HIV comorbidity in its calculations, and it connects to an underlying demographic projection model. For estimating household economic impacts, we developed a model in Excel that uses outputs from the time impact model, as well as secondary data on TB spending, household income of TB patients, and lost productivity from TB to estimate the total household spending on direct and indirect costs associated with TB. And we consider differences in household economic impacts by type of TB. So MDR TB costs more to the patient than other types of TB, and service delivery model. So active case finding has a different cost, lower cost to the patient than passive case finding approaches. And we also consider the impact of those who do not seek services and either self-cure or pass away. And just a couple key limitations. We do not estimate the cumulative cost due to premature death from TB or end-of-life costs borne to households, such as funeral expenses. Next slide. So now we get to the results. So this shows the number of people tested and notified by scenario. There are significant increases in testing under the scale-up scenario, but more cases are detected under the scenario as well compared to the baseline scenario. And you see declines over time in the total number notified under the scale-up scenario due to declines in TB incidence, which leads me to the next slide. So results from the time application show that significantly scaling up screening, contact investigation, and preventive therapy, while also improving the diagnostic algorithm, can result in significant reductions in TB incidence and TB-related mortality. And much of this reduction in TB incidence and mortality is attributable to scaling up the screening rate, which is the average time it takes to diagnose a person with TB in the time model. So the model assumes that as active case finding expands, the average amount of time it takes to diagnose a person with TB will decrease from about a year to around 7 months by 2025. Next slide. Whoops, sorry. Can you go back? Yes, okay. Compared to the base scenario, individuals would spend an estimated 42% less on direct and indirect costs associated with TB, and over 1,000 fewer individuals would experience catastrophic TB costs in 2025 under the scale-up scenario. And this translates into an 8% reduction in catastrophic TB spending. And reductions in costs borne by individuals under the scale-up scenario are a result of two factors. So first, reductions in mortality significantly reduce lost wages from premature death. And second, the scale-up of active case finding approaches, such as pagoda-based screening, reduces the average cost borne by an individual in accessing TB services. Next slide. So our findings suggest that TB patients face significant costs, particularly indirect costs in terms of lost wages. And costs are either not covered by social protection schemes, or patients, we found in one study that patients are unaware that they can be reimbursed for certain types of costs. And so we recommend the following. First, to prioritize increasing government investment in screening programs, as this intervention leads to the greatest impacts in terms of reductions in incidence and mortality. To expand service delivery models that reduce the financial burden to patients, such as active case finding and community-based DOTs, where patients do not need to travel to a facility for treatment. And third, to explore options for expanding financial protection, which could include greater integration of TB into social protection schemes like the health equity funds and social health insurance, and designing new mechanisms that cover some of the significant indirect costs borne by patients, while also making sure patients are informed of what costs are covered by existing schemes. And of course, this is in flux as policies change in terms of what types of costs could be reimbursable. So that needs to be communicated clearly to the community. And there are some lessons learned from this process. We found that holding a 5-day workshop with the TB program to thoroughly review the impact model methods and assumptions and validate each input really helped build the capacity of TB staff to do modeling work in the future, as well as to explain the results themselves to the TB program director and TB partners in country. And while Cambodia set incidence and mortality reduction targets before the modeling exercise, we recommend in general that the countries complete the modeling exercises first to inform pragmatic target setting, because it will take significant efforts for Cambodia to meet their ambitious targets based on our modeling. And lastly, we found that tying budget requests to impact modeling results can really help justify the budget figures, and it puts forward a strong case for government investment in TB. All right, I'll turn it back over to Denise. Thank you.
Thanks, Kathy. A similar exercise was done in El Salvador with a specific focus on the penitentiary system. Tom Fagan will tell us more.
Thank you, Denise, and thank you, Kathy. As Denise said, we're going to kind of cross the globe here to take a look at an example from Latin America. And as Denise mentioned, HP Plus conducted some work in El Salvador looking specifically at the TB epidemic there within the penitentiary system. So to give a brief overview, going to our first slide there, if you wouldn't mind, Denise. El Salvador has been heralded really within the region for its progress in the fight against tuberculosis. And this has been driven in large part by increases in domestic investment in the TB program. So as we see in the chart shown here, from 2015 to about 2020, domestic investment in the program has increased from about half of the estimated resource need to nearly 90% of that need over those 5 years. This has, over that period, also corresponded to a decline in support from donors, which previously took on large parts of the TB response, but now has really transitioned to kind of very focused investment on specific capacity and specifically diagnostic capacity costs that are needed to supplement what the government is spending. Notably, the government does fully fund all of its testing and treatment commodities for TB. So moving to the next slide, this increase in funding has corresponded to some pretty significant gains as well along the treatment cascade. As we see here, looking at the numbers of notified cases, treated cases, and successfully treated cases, there has been a substantial increase over the 2014 to 2017 period, and it's moving towards the goals set by the country for 2020. We also see here in this chart is that there was a substantial jump in the number of estimated cases between 2014 and 2017, and that corresponds very specifically to an increase in the number of cases within the penitentiary system. So moving on to the next slide. To put this in a little bit of context, what we can see here is the total number of cases within the general population, so those outside of the penitentiary system, which is shown by the blue bar in the figure here. And that figure really hasn't changed very much over the last decade or so. We see that it hovers around 1,500 cases nationally, which is really one of the things that El Salvador has seen as a major success. But at the same time, in the orange bar there, we see what is actually about a 20-fold increase in the number of notified TB cases between 2007 and 2017-2018, increasing from about 80 to about 2,000 cases in those two most recent years. So the majority of that increase really comes between 2013 or 14 and 2017, as we saw on the last slide, and that has really driven this need and this increased focus on the TB response within the prison system. Move forward to the next slide. So there's a few reasons why we've really seen this surge in prison TB cases. In particular, prisons in general, and particularly in El Salvador, are really a conducive environment for TB transmission. There's very severe overcrowding, poor ventilation, prisoners experience poor nutrition, and there are a number of other security-related factors that really limit the ability of health workers to effectively screen and ensure adherence to treatment for prisoners there. In El Salvador, as I'm sure many might imagine, about half of prisoners are gang affiliated. So this comes with a lot of security concerns, as I mentioned, but also stigma and discrimination around health service provision to those individuals. So overcrowding in particular is a serious issue in the prisons there. In about a 10-year period, the prison population tripled, and that has come without much of a corresponding increase in capacity or funding for the prisons. If we take a look at the figure on this slide, what we see is if we compare the funding per notified TB case within the prison system to what is spent per notified case by the Ministry of Health, or for those who are affiliated with the National Social Security Institute, EASE as it's called, the amount spent within prisons is about a fifth of what is spent by the Ministry of Health and about a tenth of what is spent by EASE per notified case. At the same time, if we look, and you can barely there because it's almost barely notable in the slide, but the total health spending by the prison system, not just TB, but total health spending per prisoner is incredibly low. It's just over about $1,000 per prisoner, which again is well below even what the Ministry of Health and EASE are spending per notified TB case within their own systems.
Hey, Tom, this is Bethany. I'm just going to hop in for a second. If everybody could please mute their line so we've got clean audio, that would be so helpful. Thanks. Back over to you, Tom.
Thank you, Bethany. So moving ahead one slide there. Perfect. Thank you. So we said earlier that El Salvador has really made great strides in increasing its domestic financial commitments to the TB response. But why then is that not really translating to adequate financing and adequate resources within the prison system? So first and foremost, it's worth noting that while government funding was about $10 million in 2017, and that actually exceeded their commitments by about 40%, it's important that we look at kind of where that money is going and who's managing that funding. So the Ministry of Health and EASE both account for about a third of total funding for the TB response in El Salvador. Another 20% or so comes from the Global Fund and external support, and that's primarily channeled through the Ministry of Health. And that leaves just about 8% of total TB funding, or about 12% of government TB expenditure, that is accounted for by the prison directorate. So I remind you, the key comparison here is we're talking about 12% of the funding going through the prison directorate, despite having actually more than half of the TB cases in El Salvador. So stepping ahead one more slide here, HP Plus conducted an exercise essentially to model both the cost and the potential impacts of increased investment in the prison TB response. And I'm not going to go into this in too much detail. We really built off of the model that Kathy spoke about earlier for Cambodia and made some additions and modifications to that. So I won't go into too many of the details. What I really want to focus on instead is sort of how we use the evidence from this model to try to make the policy case for increased investment. So there were three data points that we saw as critical to making this case. The first is the potential cost savings from new infections averted. So in the model, we were able to demonstrate how increased investment now in more rapid and comprehensive identification of cases and initiating those cases onto treatment ultimately can result in cost savings, particularly due to reduced treatment costs due to fewer new infections over the next 5 years. So that's something that certainly appeals both to the penitentiary system, the prison directorate there, as well as to other stakeholders, particularly the Ministry of Finance. Another key point for making this case is the health outcomes or the mortality related to TB within the prison system. So we were able to show that the reduction in deaths within or potentially outside of future released prisoners might reduce by as many as 1,000 due to this increased investment in the next 5 years. And while that's kind of, I think, a critical thing to show, at the same time, as I mentioned earlier, there's a lot of stigma and discrimination around prisoners in El Salvador, and that kind of information doesn't necessarily appeal to all stakeholders in this process. So we went a step further, and we also aim to demonstrate how there are potential effects on health status and health outcome beyond the prison population for individuals who might be infected within the general population due to prisoners being released either with active TB infection or with latent infection that later activates. So we were able to demonstrate that based on the model, the reduction in cases that would occur in the general population because of these released prisoners was within around 450 to 800 that could be averted based on different specifications for those scale-up scenarios for screening and treatment. So moving to our last slide here. This evidence was really used by us and partners in the Prison Directorate and the Ministry of Health to try to push for a few policy changes. And what were these changes? First and foremost, better alignment of resources with where the burden of TB is, where this caseload is. So that means more funding for the Prison Directorate specifically. While currently the MOH does subsidize provision of services within the prison system, particularly with the provision of commodities for treatment, as well as by providing capacity for lab testing through the Ministry of Health labs, this really hasn't proven to be adequate for the burden that the prison system is facing. There are severe gaps in human resources to actually conduct screening and follow-up, which is a very human resource intensive process within the prison system, and more resources are needed to be able to undertake that. The other is to also focus on really what are the determinants of TB and the TB outbreak in the prison system. So greater investment in infrastructure and ensuring that there is adequate ventilation, adequate space to house the prisoners within the penitentiary system. And lastly, also greater investment in diagnostic or laboratory capacity and potentially in improved or revised protocols to accelerate testing, as well as to potentially put prisoners who really should be considered a high risk population for TB on preventive therapy, as those, for example, with HIV or HIV co-infection currently are. So those were the three kind of big policy conclusions that came out of this work. And I'll be happy to take any questions you all have later on in the session.
Thanks, Tom. So while the Cambodia and the El Salvador experiences highlight the importance of evidence generation to ensure that policymakers are guided accordingly when planning their financing response to the TB epidemic in the countries, the Nigeria experience will discuss other sustainable financing approaches taken in the country. We have Dr. Gafar Alawodi, the country director of HP Plus Nigeria, to tell us more about the Nigeria experience. Gafar, over to you.
So thank you very much, Dennis. Good morning, good afternoon, and good evening, everyone, depending on where you are listening to us. I'll be discussing HP Plus work on sustainable financing for TB in Nigeria, which is being funded by USAID in the country. So first and foremost, let's look at the body of TB in Nigeria. Nigeria is one of the countries with highest TB body globally. In 2018 alone, 429,000 people fell ill with TB, and the same year there were 155,000 deaths, and only a quarter of new cases were detected by the particular year. Next slide. So, what target has Nigeria set for itself? So, in terms of a target, Nigeria has set an ambitious short-term targets as follows. By the year 2021, Nigeria aims to triple its case notification from just above 100,000 to more than 300,000. At the same time, double its case detection from 27% to 60%. And at the same time, achieve a massive leap in drug-resistant TB treatment and TB therapy. And at the same time, with the support of the Global Fund and USAID, expand private sector engagement and incentivize case finding. So next slide. What is the resource landscape? What is the resource constraint in Nigeria? Nigeria TB situation is a case of high burden, at the same time, high funding gap. For example, in 2019, only 81% of TB resource need. 81% of TB resources was unfunded, and at the same time, domestic resources accounted for only 4% of funds needed. So, what actions are actually needed to change this narrative, and at the same time to achieve the aspiration of the goal set by Nigerian TB control? So, one, it's obvious that we need more allocation and spending on TB at both the national and state level. It is important for us to incentivize effective private sector effort, especially in the area of case finding, and we need to evaluate what is working and scale up program. So next slide. So we're looking at what HP Plus is contributing to achieving these ambitious goals of TB control in Nigeria. So the project adopts a three-pronged approach, which includes integration of TB into social health insurance scheme, improving budget performance, and at the same time promoting strategic purchasing. So this slide is showing our effort in the area of integration of our TB into the benefit package of health insurance. And why is this important? This is important for a couple of reasons. One, according to the study done by WHO recently, 89% of drug-resistant TB and 69% of drug-susceptible TB patients incur catastrophic health expenditure. 60% of TB patients live below poverty line, and more than half of TB patients relied on loan or selling assets to pay out of pocket for TB services. So how are we addressing this issue? The first thing we did was to support at the national level, drafting of the national blueprint for integration of TB and HIV/AIDS. We did not stop there because Nigeria is a decentralized country. So at the state level, supporting Lagos and Kano State to support state to develop a state-specific roadmap for integration. And below the slide, you see indicative estimate of patients to be covered with the implementation of this integration. So next slide, still discussing strategic purchasing for strategic purchasing. We designed a trajectory of population, service, and cost coverage for different stages of advancement of integration. We also designed outcome-based provider payment mechanism to be implemented by state social insurance scheme, which is aimed at incentivizing very important outcomes like treatment completion, treatment success rate, MDR-TB enroll, and because of extremely low case detection, we want to incentivize this. So what are the challenges we have seen so far in terms of integration? We discovered that by the time we started the integration, the state social insurance scheme have already advanced their design. So it became a little bit difficult incorporating the integration into their legal and operational framework. But we are overcoming this with stakeholders engagement and evidence-based advocacy. Another challenge was a change in government officials as a result of retirement, transfer, and aftermath of election. But we put on our political economy hat to get buy-in of a current political office holder. And another challenge is low institutional capacity for health insurance system design and management. And that's why we invested on capacity building through formal workshops and handholding for the implementers of this social health insurance scheme. So next slide, we'll be looking at our work in the area of improving budget performance and what is our approach. We do is to do public financial management analysis through PFM diagnosis to understand the public financial landscape, institutions and processes and obstacles that militate against optimal allocation and use of funds. This is followed by capacity building, especially in the area of project tracking and effective memo writing, and advocacy to the policymakers across sectors, including the parliament and budget agencies. Then part of what we are looking at is that once the funds starts flowing, to invest time in effective and efficient utilization of the funds as well. So next slide, I'll be quickly talking about challenges in budget and execution for TB and what did we discover from public financial management analysis in Lagos and Kano State. So the key findings were that one, budget allocation for TB has increased in the last 3 years, but budget execution is poor during the period as a result of non-release of funds. And some of the reasons for non-release of funds included low prioritization of TB in the state budget due to overdependence on donor funding, low capacity of to develop evidence-based memo to quest for money and insufficient evidence for TB advocacy to increase domestic resource mobilization. So next slide, we'll be looking at what are the key initial lessons since the sustainable financing for TB started more than a year ago. One, it is very important for us to align existing finance with the existing financing policy trust. We discovered that resource mobilization efforts will gain more traction if we align with the existing government policy trust. Then two, evidence-based domestic resource mobilization yields better results, as lack of evidence-based advocacy is very, very difficult. Then three, intersectoral collaboration is very, very crucial. We need more than health agencies. That's the most clear in our approach. Then domestic resource mobilization effort is a marathon, not a sprint, because it takes time to build trust, relationship, and capacity needed to change the behavior in terms of our funding. And lastly, we discovered that the endemic notion that TB financing is a domain of external funder is usually the first order to scale in the work around domestic resource mobilization. I would like to stop here. Thank you.
Thanks, Gafar. So all three case studies that we've heard about have demonstrated various approaches to sustainable financing of TB, adjusted to each context and focusing on the government response. The private sector also has a role to play. So Orin Dutta, the Technical Director for Health Financing for the HP Plus project, is here to discuss the potential to leverage the private sector to ensure that the TB response is adequately and sustainably financed. Thanks, Orin, for joining us today. The private sector has been seen as an untapped potential in many countries. In the current situation we are in, the COVID pandemic, we have observed how the private sector has sprung into action or how they have been mobilized to help with the response. For TB in particular, what do you see as entry points for the private sector from a financing angle?
Thank you so much, Denise. So I don't have slides, so let me respond by listing some ideas and try to be brief, so we have good time for questions. So I do think that the private sector has been tapped in the TB response in a lot of countries. So what I'm focusing on is how financing arrangements could help us make that increase in scale as well as be more effective. So just as a quick summary, we have usually the three traditional entry points for the private sector into the TB program. So the first is that we have the use of the private sector to screen and refer cases, and where possible to diagnose and notify where the capacity exists. So we know that this is useful because a lot of people who are suspected TB cases and may have the symptoms really enter their care journey through providers at the lower levels like pharmacies, medicine vendors, and the like. So new efforts that we're seeing are focused on incentivizing the right behavior at this level. So this means using decision aids to help conduct screening so that the right cases are being referred, and possibly even giving incentives to that level to conduct this screening to really try to increase the behaviors that we want to see. So we want to have the private sector, where it doesn't have the capacity to diagnose cases itself, to send these suspected cases to the private sector, to the public sector. But where we have seen cases being managed in the private sector itself, usually out-of-pocket fees are charged, and I think we've seen some evidence today about the catastrophic impact on TB patients of these types of user fees, as well as the indirect costs. So where TB has been integrated into the treatment program, so where the private sector has been integrated into the TB treatment program, we want to incentivize quality of care, of course, but we also want to look into issues of affordability and financial protection. So that's a second major entry point. And third, we have had a larger discussion for a very long time about the public-private mix, and that includes public-private partnerships. So that's a larger agenda around making sure that we have private sector bodies involved in the entire TB response, not just in the screening, identification, notification, and case management, but also taking a broader look on TB prevention and better lung health, and working with the private sector, especially in workforces that have some risks to lung health. So that is kind of like the big picture of how the private sector is being tapped. And we, of course, will continue to see a movement in terms of tapping the private sector's capacity to provide labs. As you said, COVID is an example of how this is happening in real time, and also in sample transport, logistic management, informatics, and digital solutions. And we have a web blog today on that subject as well. Over to you.
So you mentioned these 3 entry points. Do you see any major gaps in how countries are financing TB when it comes to capitalizing on those entry points?
Yeah, so this is the main focus of my comments. I think a lot of hands are tied in TB programs, not just because I think there is some sense that the private sector would not be the appropriate vehicle for expansion, given some of the issues in how TB patients would have to pay for services and not resolving how out-of-pocket costs will be covered. So hands are tied because a lot of TB program funding, as Ghaffar mentioned, is still project and grant-based funding, whether from external partners or the national government. And these are channeled through, on-budget support or specifically to implementers. And so domestic budgetary funding is a little rigid in order to capitalize on the types of contracts and payment models that would make sense for the private sector and that would be attractive to them. Whether this is in the supply chain or in expanding the specific services for screening, referral, notification, and then of course case management and diagnostics where that makes sense. So there are 2 possibly big trends that would perhaps lead us to a better future in terms of scaling up the private sector engagement. One is, of course, what Ghaffar mentioned in Nigeria is the scale up of TB services into insurance. And that has multiple benefits, but one would be the ability to start tapping the impaneled or contracted providers of the insurance scheme to start providing those TB services that have been integrated with the benefits. So this would allow us to use a performance-based standard and also really drive for efficiency and clinical quality in the services through the sort of purchasing power that the insurance scheme can exert. The other one is a larger subject on digital health. So I think we've all had this discussion around digital health being an opportunity in infectious disease control. And specifically, digital financial services for health are really making a lot of payment possibilities sort of become clear in health programs and especially in Africa. So these digital financial models allow us to skip a lot of the paper-based systems failings when it comes to dealing with the private sector, especially a very disorganized and decentralized private sector, like the lowest level pharmacies and patent medicine vendors. So we can see that making digital payments using mobile money to incentivize proper behaviors like screening and referral, or even paying for services like diagnosis, would allow a much faster scale, as well as create digital verification and reporting mechanisms that would be easier to scale up even further.
And are there any countries that we can look to that have started leveraging the private sector in the TB response?
Thanks. I think there are some countries that we can look at that have had successful private sector engagement models, and certainly Nigeria has recently scaled up its engagement with the private sector on screening and referral in a big way, and including paying monetary incentives. But one country that I would like to talk to, just to go back to Southeast Asia where we started, is Indonesia. And this is an interesting country to look at because it has a very large national health insurance scheme that has an extensive network of private providers that it's contracted for, both those at the primary care level, that is capitation, and as well as the hospital sector. TB services are integrated into the benefits, but they're not necessarily paid for in a way that would incentivize the behaviors that we want. So what do we mean by this? So one issue is that a lot of cases are seen in the private sector, and many of those cases are handled by private clinics directly, and they prescribe the first-line regimens, but these cases are not being notified. And one of the reasons why the notification rate is not high and is leading to missing cases is that the private sector does not feel sufficient incentives exist in handling TB cases under the National Health Insurance Scheme, mostly because of the amount of money paid through capitation. So this is an example where changing the payment model itself, rather than instituting any new types of payments, it's really the design that could help incentivize proper behaviors and lead us to the TB elimination agenda that we want to see. I think these are the types of lessons that we will increasingly try to bring out and really apply, even in countries that don't have scaled up insurance, to see how financing models, mechanisms can really help us speed up and accelerate on TB elimination. Over to you.
Thanks, Erin. We'll end the discussion here and open the floor to questions from the audience. Over to you, Bethany.
Great. Thanks, Denise and Erin. Really appreciated that discussion. So we're going to go over now to Q&A, and folks are welcome to type their questions at any time via the chat box on the right-hand side of your screen. And I'll start with the first question that came in. Actually, I'll read the first two and kick us off that way. So the first one is a clarification question just for you, Kathy. What does pagoda-based screening mean? And then the second one, this is open to all panelists. How do you all think TB financing will be impacted by COVID-19? So Kathy,
Thanks,
why don't we
Bethany.
start with you? Perfect. Go ahead.
Sure. So the pagoda-based screening program in Cambodia is where the TB program actually collects sputum samples from the elderly primarily who frequent pagodas throughout Cambodia. And this is a way for them to access the elderly who are actually a more at-risk population. They have a higher TB prevalence and incidence rates than a lot of other populations in Cambodia. So it's a way for them to actively case find in that community, and then also refer them appropriately to follow-up services.
Great, thanks, Kathy. And just to clarify, in case the pagoda is a new term, that's a temple in one's community. Is that accurate?
Yeah. Yes.
Perfect. Thanks. And now I'll open it to any panelist who wants to comment on the COVID-19 question. Totally open floor for anybody who has something to add.
This is Tom. I'm happy to share some thoughts here. I mean, I think this is very much, as with everything related to COVID-19, an evolving question, and the answers are likewise evolving. I think that in somewhere like El Salvador and with many Latin American countries, they have taken some very swift steps to try to prevent further spread of coronavirus, which hopefully are yielding some benefits. So I think that in the short term, the impacts are probably pretty minimal. It's certainly, I think there's a tendency to shift financing maybe towards that response and away from other infectious disease areas. But I think we'll have to see how it plays out in terms of what the need for that ends up being there. I mean, they're under essentially a 30-day lockdown. So that and with, I believe, only 9 confirmed cases. So I think that's one side of things. Certainly, if this were to be something that affected the prison system, we're talking about, again, a population that is very much at risk for rapid spread of something like COVID-19 with a lot of pre-existing health conditions, with tuberculosis in particular. So if that were to happen, if we were to go in that direction, the need for resources would grow exponentially to be able to provide those services, to provide DOTS, the directly observed treatment for those people, and to provide all of the protective equipment necessary to do that. So, again, there's 2 different ways that this could go at this point. But it's difficult to say, I think, until we see over the next month how that develops in El Salvador.
Hi, Bethany, this is Lorraine. So just to build on Tom's point and maybe a few other things that are coming up. So the clinical issues are definitely something we'll need to watch out for. I mean, obviously, COVID-19 has severe impact on the lungs, in severe morbidity cases. So that's going to be a issue certainly in TB populations. But at the health system level, we're seeing a few things that we should watch out for. One is the possible use of diagnostic capacity, especially use of gene expert machines that are being deployed in this massive scale up that's happening on testing for COVID-19. So how does that affect the backlog for TB diagnostics? Second is in terms of physical distancing. Obviously, DOTS requires some face-to-face interaction between the provider and the patient, especially during the intensive phase. So how will that be impacted as social distancing or physical distancing, as we're calling it now, is rolled out? How do patients get access to their medication? And of course, to the clinical visits and laboratories. So these are not just peculiar or specific to TB. Other disease programs, health programs are facing these. And I think this is again a place where telemedicine or video enabled DOTS will really start to be looked at again as possible ways to scale up. But there are financing costs to telemedicine. It is not costless. The initial programs and giving access to clients and patients to that technology is not trivial. It needs to be rolled out. But this is again a chance to look at those solutions.
If I may contribute to that question, I think the question of how COVID-19 affects our TB financing is an interesting one for Nigeria, especially because Nigeria microfiscal dynamics is vulnerable to external shock. What do I mean? Nigeria economy is oil economy. The price of oil is going down, which has implications for the revenue accruable to the government, and which further has implications for what government is able to spend on or not spend on. So we envisage a very, very hard time in a short to medium time in terms of ability of government to spend more on generally and probably TB specifically. But what does that mean for us? What it means for us is that we have to up our game in terms of advancing the case as much as possible to convince the government to spend more. At the same time, it's not only about spending more, but spend well as well. The little resources that government is spending, we have to look for a way to be more efficient in spending the resources. Then again, that further makes the case for the integration effort in terms of integrating TB services into the health insurance scheme as much as possible to mitigate the impact of this. I think, and again, in terms of external financing, we're likely to face more difficulty because a lot of resources are going to the COVID-19 response, which further advances the case for domestic resource mobilization for TB.
Thank you so much, Gafar, Arin, and Tom. I'm going to read aloud the next question, which is, how can we support national TB programs to generate impact modeling evidence on their own in the future?
I can take that one, Bethany. So I think that the case of Cambodia, it really showed that doing the modeling exercise side by side with the TB program, where we did a simultaneous training and exercise, really helped to build capacity. But that sort of one-off workshop approach is not great for sustaining future changes to the model. So you really need to set up an institutionalization plan as well that includes refresher trainings on modeling and designating roles and responsibilities to TB program staff to be in charge of modeling and doing it at the correct times of the year to inform target setting and prioritization.
Great. Thanks so much, Kathy. Next question is, are there examples of focused private sector investments in expanding diagnostic capacity for TB by government or private investors?
I can start that maybe, and then Gafar may want to come in on the experience from Nigeria. So generally, I think what we've seen that in placing gene expert machines in the private sector and really working with the private sector to expand that capacity, there have been a few different types of models. One is, of course, completely donation-based models that are often funded by the Global Fund and external partners. Those work, but scale, of course, is a limitation there. How much can be achieved through donated equipment, or even subsidized equipment where there is an arrangement with the original equipment manufacturer, in this case CEFID. The second is the possibilities of lease loan arrangements where the expansion of diagnostic capacity, especially molecular diagnostics, has been achieved through basically subsidized arrangements where the equipment is long-term lease to private labs with a guarantee of a minimum monthly sort of volume. And these are arrangements that are brokered between the private sector or specific networks of facilities and the manufacturer, often by a third party, whether it's government or a public-private partnership. So these are really innovative models, and we've seen them in some countries in Asia and Africa and also Central Asia. The third is, of course, where the private sector makes the investment itself, and I'm not aware of large-scale efforts on this front, but the investments are made by individual clinics, hospitals, and the diagnostic capacity is, of course, multimodal, so it can be used for more than one health area. And this is where reimbursement for diagnosis in the private sector really becomes important. And the points that I had made earlier really come back about how do you make sure there's a contractual mechanism that allows for patients who are seen in the private sector and whose diagnoses are managed in the private sector can also be compensated by an insurance scheme or by a public sector using set fees. So hopefully that helps. Ghaffar, do you have any comment on what's happening in Nigeria?
So thank you very much, Aaron. I think there are a couple of interesting examples of how private sector investment is helping the whole diagnostic response. One, using the language I introduced, maybe the donation-based, apart from the investment of Global Fund, we have seen a number of private organizations that are donating diagnostics equipment for TB response. There is these particular academic partners, a group of oil companies that came together to support the national program in area of diagnostics for TB, which is actually solving part of the diagnostic problem. And again, in terms of private providers now, I think there is a lot of interesting collaboration between the national TB and the private providers in terms of collaborating with them. The greatest problem with the TB in Nigeria, the number of mixed cases, especially in the private facilities, because there was no incentive for the private provider to look for the cases of TB, to screen them, to detect them, and to notify them. So I think the collaboration between the national TB and the private sector with some USAID project is actually very, very promising, and we have seen in recent time where a number of cases notified from private facilities are on the rise as a result of this collaboration. I think it's worth expanding such collaboration because it's happening as part of a project, and there's a need to escalate it to the other part of the country as well.
Wonderful. Thanks so much, Ghaffar and Arin. I'm checking the time now, and we've got about 3 minutes till we wrap, so we can take one more question. And so the final one is for Dr. Ghaffar. What TB reimbursement models are you exploring with social health insurance schemes in Nigeria?
So I think to start with, because the social health insurance scheme I just picking up, we have been very careful in terms of what to introduce. So, and the social health insurance scheme are starting with the pay for service and capitation. So we're in the process of building on what they are doing, and then you have to realize that the state health insurance scheme, some of them have not even started enrolling patients and all this stuff. So we are looking at, irrespective of what provider payment mechanisms is being used. The focus is on how to incentivize key outcomes in terms of cases, number of treatment completed, treatment success rates, and everything to actually build into the provider payment mechanism while helping them to design a provider payment mechanism.
Great. Thank you so much. Do any other panelists have anything they wanted to add to that response? All right. So we are almost at time. So I'll just wrap it up here. I just want to thank so much all of our wonderful panelists, Denise, Kathy, Tom, Dr. Ghaffar, Arin. We really, really appreciate appreciate you all taking the time for compiling this really in-depth presentation. And thank you to all of our attendees. I know this was a little bit confusing to have the platform change at the last minute, and we know that there are many demands on your time in this very interesting climate that we're in. So truly, thank you all. Please do share the recording with your colleagues, and enjoy the rest of your day and your week. Take care. Thanks, everyone.
Thank you.